Thanks for listening to the Wild Health Podcast. For the foreseeable future, you're not going to hear our normal intro or outro here. We're going to be releasing episodes very frequently as things are changing. This channel will be used for a very specific purpose. Number one, to communicate with our patients. We're somewhat overwhelmed, and the more we can communicate breaking news and recommendations from us to our patients all at once, the better. So if you're a patient, we're here for you if you need us, but if possible, please tune in here so we can both keep you up to date and conserve our time for the most critical tasks. Feel free to share this with friends and colleagues as well. Number two, we've organized as a group. We have infectious disease specialists, ER doctors, critical care doctors, and in total dozens of MDs, PhDs, and frontline clinicians who are going to be constantly evaluating the news and emerging evidence. We're then going to summarize and translate that for you here every day on the podcast. The speed of change with the circumstances will make us look foolish at times, but we're committed to pouring all of our resources and energy into doing what we can to help and make a difference. You can also follow our updates at wildhealth.com or our Instagram account at wildhealthmd. And if you're a patient, we're here for you. Please tune in here for the updates and let us know how we can help.
Hey everybody, welcome back to the Wild Health Podcast and this COVID-19 update. I've got with me today Dr. Mike Stone.
Hey Mike, how's it going?
Going good, man. How are you doing this weekend?
Doing well. I think we're at work as opposed to maybe some of the federal government, I hear.
Yeah, you and I talked about this a little bit before we started recording this podcast. I recently got a screenshot from a friend from the CDC website, which was basically recommending, if you happen to run out of PPE, that first-line healthcare providers wear bandanas as protection. And
do they have recommendations about whether they should be blue or red bandanas, or they just kind of whatever you want?
I don't want to go off on a tangent here or bash the CDC too much, or our governmental response to this whole thing, but this is ridiculous. I mean, I'm hearing from my friends working on the front lines that they're having to, drive from hardware store to hardware store to try to find N95 masks. Some of them are buying respirators. I've got my next door neighbor who is actually sewing surgical masks for healthcare providers. We've got people who are shipping N95s and PPEs across the country to friends and loved ones across the country who don't have access to them. I can't believe we're here.
It's really mind-blowing. And I mean, we could do an entire podcast about the PPE crisis. I think we both want to say thank you to the people who are out there actually combating this, especially in these uncertain times of self-protection with PPE. So for all the healthcare workers, the paramedics, EMTs, nurses, docs, PAs, NPs, everybody who's out there trying to do the best that they can in this kind of situation. We both know what it's like to actually be taking care of sick patients and wondering if there's enough masks. And it's mind-blowing that we're at a stage right now where we're experiencing this in 2020 in the U.S.
I've got friends and colleagues that are, basically isolating themselves from their families. They're living in their garage. They're living in their RV parked in the parking lot of the hospital. I mean, thank you so much to all of the frontline workers who are taking the brunt of this disease in this pandemic. So let's let's go ahead and do some updates, Mike. We'll start off with the United States. And consistent with my banter regarding the CDC's recommendation about bandanas, we can't actually report any number updates from the CDC because they are also apparently taking the weekend off. They have not reported any updates since the 20th and don't plan to do so again until Monday. So I had to get our data today from the interwebs. Used a site called Worldometers, and they reported a total of 32,356 cases and 414 deaths in the United States. That's actually an increase of 27%, which is significantly lower than what we've seen in the last 2 days in number of deaths. I don't know how reliable this data is because it's not coming from the CDC. So what we might end up seeing is a fairly large jump tomorrow. We'll have to see what tomorrow brings when more data comes in. In U.S. news, as most of you know who are parents, school closures are basically across the country. 54 million students have been sent home in some states for the rest of the academic year. Only 5 states right now have not closed schools. That's Idaho, Iowa, Maine, Nebraska, and Wyoming. A lot of the central states in the country have not been hit as hard yet. And although they have not officially closed schools, a lot of the counties have sent students home from those locations.
Wow. Yeah. So, certainly upticking pretty strongly in the U.S. Globally, the pandemic's interestingly hitting some countries a lot harder than others. According to the Financial Times database, Italy, Spain, and the UK have had more deaths due to COVID-19 than China did at the same stage of the outbreak there. The same data shows the U.S. Is, however, the only country to have about the same number of cases as China did at the same stage. In the earlier stages, South Korea's rate of daily increases was rapidly overtaking China's, and we'll talk more about South Korea in a little while. But the country's huge test and trace program. So, really, I think everybody's aware that South Korea really ramped up their drive-through testing and their epidemiologic investigation of positives, and they managed to really quickly flatten the curve. And they really are not reporting a lot of new cases on a daily basis. Little discouragingly, China reported no new cases over 3 days, but reported 46 new cases today and 6 new deaths. So not yet out of the woods in China as of yet.
The live data does seem a little bit harder to get over the weekend, so we'll get back to some more specifics and try to update everybody tomorrow with more case numbers and such. In terms of wild health updates, the big announcement that we've got for our patients is that the machine that Wild Health purchased to run rapid COVID testing was just approved on Friday by the FDA. So it's received clearance for this new testing modality for COVID, which can be run in the office and can be basically run on a desktop by office staff. It's very easy to use, and the turnaround is closer to 45 minutes to 1 hour, as opposed to what we're seeing from current lab testing, which is on the order of days. So we'll get an update from Dr. Taylor Bright and Matt Dawson on that tomorrow with some more specifics on Wild Health COVID testing. Let's talk about some literature. Mike, I think you've got a couple of studies you wanted to tell us about.
Yeah, absolutely. And just one other nod to testing. I mean, I think we can advise our listeners and the general public that we're going to see a humongous uptake in cases as a result of testing. Not just as a result of spread, which is also going to be responsible for new cases, but as we're getting more availability, obviously these numbers are going to go way higher when you start testing a broader population. And
what we're seeing is a lot of people are recommending looking closer at the death rate than actually the number of cases, because we do know there's such a limited number of tests. The death rate is a more consistent measure of the uptick in the virus in the community, I think.
Yeah, for sure. So interesting studies in the in the last week. Lancet, March 19th, so just a couple of days ago, studying viral dynamics in mild and severe cases of COVID-19, and they tested viral loads in mild and severe cases. And may not be a huge surprise, but we really don't know that much about this virus yet. And I think even what may seem a sort of trivial is important to get our base assumptions right. And mild cases had lower viral shedding throughout the illness, earlier clearance of the virus, and 90% of the mild cases tested negative by day 10. And you contrast that with the severe cases, they continued to test positive longer than that and had high viral shedding throughout the entire illness. So this is interesting in a couple of ways. Number one, a possible marker for progression of illness. So if we can follow a viral load in these patients and there's testing available that allows us to do that rapidly, we can probably get a sense of predicting how severe a case is going to be. Also indicates that severe cases are likely more contagious than mild cases, which is a little bit reassuring that the asymptomatic or minimally symptomatic cases that are out there that we know are out there in large numbers, if we just practice social distancing and keep our heads about us, those are not likely to be carriers who are going to be highly infectious to those around them. So we don't know the answer in terms of how infectious, and obviously for healthcare providers, droplet masks while they're still available, and routine precautions, I think, for every patient encounter, regardless of whether it's a suggestive viral illness kind of encounter, is still worthwhile. But this is interesting that the viral loads do seem to correlate with severity of disease and duration of viral shedding. The other study that I thought was worth mentioning was out of Korea, as we kind of nodded to earlier. So this is from the International Journal of Infectious Disease from March 17th, and transmission potential and severity of COVID-19 in South Korea. And this has to do with the RT value. And the RT value, as I understand it, and Mike, we know one of the very few things we know in the midst of this epidemic is that you're smarter than me. So if I get this wrong, you let me know. But the RT value, as far as I understand, is the infectiousness of the virus in a particular environment. So sort of if one person has it, how many people on average around them are they going to transmit it to in a specific environment, as opposed to just the R naught value, which is how infectious is it in sort of a lab controlled situation. So, if you're in Antarctica and you're the only person for 1,000 miles around, your RT is 0 because you can't infect anybody. Whereas if you're, let's say in prison, we would think you'd have a much higher RT value. Am I on base?
That's my understanding. So clearly, if there's an epidemiologist listening who disagrees with us, let us know. But that's my understanding based on reading the literature and the review that I've done about different R values.
Yeah. So okay. So we're gonna go with that assumption for now, and please feel free to correct us. Neither of us are trained epidemiologists, nor do we pretend to be. But from reading this paper, it looks like the RT value in South Korea was about 1.5. So for every positive case, they transmitted to 1.5 additional cases on average. Obviously, you can't transmit to a half a person. The case fatality rate in men was 1.1%, and in women was 0.4%. And we have seen that across different environments beyond Korea. It does seem that men are having worse outcomes than women. And then just for reference, we're seeing that this RT value is 1.5 in South Korea. In the early China cases, before they were aggressively controlling, the RT was 2 to 7. And if you look at the Princess cruise ship, the RT was about 11. So what this tells us is, sustained disease transmission in South Korea is still ongoing. And if you implement things like social distancing, you really have a chance to stem the number of new cases, not only domestically, but also exported to other countries. And that social distancing works. South Korea was really at the forefront of this. And I think we're starting to see some data now that lower transmission rate is a testament to their social distancing methods and emphasis, and that they really managed to flatten the curve as a result.
Yeah, so this is actually, I think, probably some good news. This is some data to suggest that what we're doing should actually work, and hopefully we'll be seeing that in the near future. Along the same lines of good news, there's 2 new studies to talk about, Mike, that I think are generally thought of as positive. So one of these is out of China. This was released on March 10th. And then the other is some data that's come out of MIT, and both of them are suggesting that warmer weather may actually slow down the spread of the coronavirus. So researchers found that most cases occurred in regions with low temperatures, so between 37.4 and 62.6 degrees Fahrenheit, and that temperature dependency appears to be holding true so far, at least in the United States. So warmer states like Arizona, Florida, Texas are seeing slower outbreak and growth than the colder ones like Washington, New York, Colorado, and California is kind of in between. So this could mean good things considering we are on spring. We're looking at summer coming, and the projections are now suggesting we're going to see a change in the R value based on an increase in temperature. So the study out of China suggested a reduction in the R value of about 0.03, which is a moderate decrease in the infectivity of the disease based on temperature. So I think generally the scientific community is taking this as a positive and being hopeful that we're going to see with warmer weather, truly a reduction in the transmissibility of the disease.
Well, here's hoping, and whether that holds through the fall when it gets cold again, or whether we just see the same thing next winter. I think it's these are all let's just deal with what's in front of us right now, and then we can deal with what it looks like
I'll
come
take
October.
any positive couple of months I can get at this point.
Yeah, we'll take it. We'll take it.
Should we do some
So
questions?
some interesting literature and hopefully some positive news in there. Answers to Instagram and Facebook questions. We had a question: what's the turnaround time for COVID-19 testing? Complex question because some of it's going through LabCorp and some's going through Quest and some's going through local hospital systems or departments of health. If you were tested through Wild Health or even elsewhere, I think you're looking at getting a result within 7 days. Sometimes it's going to be, as soon as 3 days, and most of the time 4 to 7 days. Obviously, national shipping and fulfillment and strain have slowed the normal processing times. For our patients, when we see your results, we will let you know immediately. And definitely, I'm interested to hear more from Matt and Taylor tomorrow about the rapid turnaround test and that 45-minute test. What we can do in terms of cutting that time even closer.
Certainly. Another question that we got was. Can UV light kill the virus? I honestly had to do some digging into this one. I don't know have you noticed, Mike, that in the hospital they're starting to use UV lights over the last few years at least to clean rooms.
Yeah.
So I assumed that there was some bactericidal, antiviral efficacy of the lights, but truly did not know this off the top of my head. So I did have to look it up. It turns out that there's a very narrow spectrum of UV light that's called UVC light, runs about 220 to 222 nanometers, and it's actually been shown to kill MRSA bacteria and other viruses, specifically lots of research in the influenza virus. And it's interesting because it's safe for humans because the narrow range of light doesn't actually penetrate the dead skin cells on our skin, and it doesn't penetrate the tear layer on our eyes. But because bacteria and viruses don't have those protective layers, can go straight into the bacteria and viruses, disrupt their DNA, and then leave them inactive, basically. And there's been several studies on this showing it's effective against MRSA, it's effective against influenza. I was able to find 2 studies on SARS. These are both on the SARS-CoV-1 virus, so I have not seen any data yet on the SARS-CoV-2 virus. The viruses are very similar. I suspect they're going to have a similar amount of efficacy, but truly no data specifically on CoV-2. This one actually did show that you could basically kill the CoV-1 virus if you were using a high enough energy of the UVC light, and that's that amount of energy is somewhere around 0.2 joules per centimeter squared. So does the UVC light that you buy on Amazon for $50 work against CoV-1 and CoV-2? I have absolutely no clue. But if you can somehow figure out the actual power of your UV light, and if you can get it up to 0.2 joules per centimeter squared, then according to the data, that should be killing the virus.
And so really, in terms of like practical use, this is most likely useful in healthcare settings in terms of, mitigating the viral load on surfaces and, in room cleans and, just generally taking the environment and decreasing the amount of live virus. Obviously, all of the routine stuff that we're talking about, 6 feet minimum distance, excellent hand washing and hand hygiene and all of that stuff is going to, and social distancing, that's going to get you a lot further than buying a bunch of UV lights and resuming your normal activities. So
I'm certainly not recommending that. But what I am doing, Mike, is I'm actually taking that N95 that I have to reuse because the country doesn't have enough N95 masks. And then when I come home, I'm putting it outside in the sun, and it sits outside in the sun and gets UV light and heat all day long. And I can't imagine there's any downside to that.
No, and I think for disinfecting PPE and surfaces, UV light may turn out to be a really great tool that we haven't explored fully yet. So I'm not trying to say there's no benefit, but I think in terms of your own personal risk, it's probably going to have a benefit for decontaminating the environment and your PPE more than it is for preventing sort of person-to-person transmission.
And just for clarity, just because I have a feeling we're going to get this question, this does not include tanning beds. So I'm not sure a tanning bed or a sauna is necessarily going to do that much benefit for you for killing the bacteria. But yeah, interesting data for sure.
Could make you look real good, and the sauna's got so much benefit. I mean, why wouldn't you get in the sauna? It's not going to help you for SARS-CoV-2, but sauna's always a good idea.
All right, Mike. Well, thanks for your time today. This concludes our Wild Health update. Everybody, take care.
Take it easy, guys.
Thanks so much for listening to this COVID-19 update. Please send us your questions or follow along on Instagram and Facebook at Wild Health MD. And just to be clear, this is not medical advice. No patient-physician relationship has been established, and this resource is really for general informational purposes only. And finally, if you want to spread the word, please send this podcast to friends and family and give us a review on iTunes.